We're good?
Just one moment. I have to mute it.
I need like a light action.
Hello, web shadowers. Thank you all for attending our session this afternoon.
Today, we are honored to host Dr. Cole, who will be teaching us about PM&R and cancer rehabilitation.
And as always, please remember that the Google form will be posted in the chat box and in the description of this video at the end. And please stick around at the end for more information about our upcoming roundup.
With that being said, Dr. Cole, you may start whenever you're ready.
Thank you. Thank you so much, Web Shadowers, for having me. It is a pleasure and honor to be here today and hopefully inspire the future generation of physicians. My name is Dr. Alyssa Cole, and I will be going over PM&R and cancer rehab as part of this shadowing session. If you have any questions, you can always reach out to me. I will be leaving my contact information, or you can follow me on Instagram at Dr.Cole, C-O-L-E. To begin, I have no disclosures. So a little outline of what I will be discussing. I'm going to talk about my story and my reason for choosing osteopathic medicine. I'm also going to discuss why PM&R, which is physical medicine and rehabilitation, in case you did not know. Also, why cancer rehabilitation, a subspecialty of PM&R. I'll be giving a case example and some key takeaways from that, as well as medical advice for what I wish I knew as a pre-med student. So my story, I was born, raised, and educated in New England. So if you hear me say wicked, that's probably why. I earned a dual degree in classics and biology. So I received my Bachelor of Arts in classics because I have a passion for the arts, and then a Bachelor of Science in biology because I have a passion for science. The classic side was very helpful for me going into medicine, since Latin and Greek are fundamental languages that help shape a lot of the medical terminology that we see as physicians. I graduated from an osteopathic medical school, so I am a DO, and I'm happy to answer any questions about DO versus MD. I did my PM&R residency in Philadelphia, and I am now the first cancer rehabilitation fellow here in Philadelphia. As I said, I have a passion for the arts and sciences, which is what led me to travel the world, especially during college, from studying architecture in Italy to researching plants in the Netherlands. And this is really just to tell you all that if somebody tells you you cannot study abroad while you are in or while you are achieving your pre-medical requirements, that's not true. You can study abroad. I studied abroad at least 3 times. I also studied theater in England. So I just want you to know that it is possible, and also to encourage you to really get involved. And that's this next section. So prior to medical school, I fostered a strong appreciation for different cultures and human connection during my travels, as well as while I was volunteering as an EMT. So this was during college. I really took advantage of every opportunity I could to seek out medical opportunities for shadowing, for example, like what all of you viewers are doing right now. And I volunteered not just as an EMT, but also in the emergency room. And of course, I mentioned research, so it really helps to have a well-rounded application when applying for medical school. So now moving on to osteopathic medicine, and I feel as though A.T. Still, this quote by A.T. Still, who is the founder of osteopathic medicine, he is an MD who founded the DO philosophy. I feel like this quote really reflects our clinical practice and approach. So to find health should be the object of the doctor. Anyone can find disease. And that really stuck with me and aligned with my own goals for becoming a physician and how I wanted to shape my clinical approach to patient care. I really wanted a more holistic approach, and I liked that they offered training in osteopathic manipulative medicine. So you kind of have this additional tool in your back pocket, right at your fingertips, literally, to offer patients when they come in to see you. I'm a huge advocate for the osteopathic medical philosophy. So if you have, again, any questions, and it looks like some questions are coming in, I have a chat coming up. So somebody's asking about the major differences between DO and MD, and I will be showing you a slide. I won't go into too much detail because I don't want to read off the slide, and I want to get to really the meat of this lecture, which is, of course, my specialty and subspecialty. But I will show that to you. And then if you have additional questions, you can find more information on my blog at dailydoseofvita.blogspot.com. I'll leave that at the end as well. Or you can, again, find me on social media at dr.cole. And I have a lot of information there. But I am very much an advocate for being a DO. I work side by side with MDs. I went to an allopathic residency program. I know that the residency programs have since merged, but I work side by side with MDs, and I really like having this tool of being able to practice OMM and have this more kind of holistic approach with patient care in my cancer rehab clinic. As an advocate for being a DO, I also work closely with the American Osteopathic Association, and I had helped to champion the DO Proud campaign. So again, if you have any questions about being a DO, I am more than happy to answer them after the lecture too. So these are the main differences that I was kind of talking about to answer whoever had asked that question about the major differences between DO and MD. They're, for the most part, very similar. It's just a little bit different in terms of their approach and some of the board exam requirements. And we also have the osteopathic manipulative medicine training. So that's additional training and education that we have as DOs that MDs don't receive. And you can also pursue all specialties, whether you're a DO or an MD, except MDs, of course, they can't pursue any sort of specialty in osteopathic manipulative medicine because they haven't been trained in that. And then these are the DO tenets. So again, I won't read these because I don't want to bore you and read off the slides, but I think these are really important if you are considering an osteopathic medical school to ensure that you read these, understand these, and really kind of go into your interviews and your medical school application personal statement with a good foundation of what the osteopathic tenets are. So now getting into why PM&R. So why physical medicine and rehabilitation? And of course, I wanted to add a little bit of humor. So you can see doctors are supposed to know everything, including where somebody's pain is. But really, pain does become a huge part of our specialty as well, as I'm sure it does with every other specialty out there. So we are the doctors known as physiatrists or physical medicine and rehab doctors, whose goal is to optimize function and improve quality of life for our patients. And you'll see me looking over here because I have a couple of notes over here. I just want to make sure that I hit everything for you guys while I'm talking. So for me personally, I chose PM&R because I felt like I had a really strong sense of anatomy, especially with my osteopathic manipulative medicine background, as well as a true love for the neurologic system, the musculoskeletal systems. And I wanted a specialty that kind of combined all of those. So there are several different areas in PM&R that you can pursue in terms of a subspecialty if you decide to, or you can be a general physiatrist. But those include spinal cord injury, traumatic brain injury. You can go into palliative care. You can go into pain management, spine, and sports medicine, for example, is another fellowship. As well as, of course, cancer rehabilitation. So it's really this small hidden gem of a field that is definitely growing. But I think that we're going to be in need of more physiatrists to kind of fill the gap in care that's out there, and especially cancer rehabilitation specialists. So for me, my experience with rehabilitation actually started with a preceptorship in medical school. That's one thing I want to make sure that you guys know is when you're looking for a medical school, look for one that offers early clinical exposure, because you want to kind of have a little bit of groundwork before you go into your clinical rotations in like your third and fourth year of medical school. You want to have some idea of the different specialties out there. And my medical school was great because we did have that. And one of the preceptorships I did was at a rehabilitation facility. And I remember seeing a stroke patient who, a month before I saw that patient, she wasn't able to stand. And when I went to see her, she was able to walk across the room to hug her children. And just hearing about that progress in her function and achieving these milestones, it just made me want to really be involved in her care as a physician. And I hadn't heard of the field of physical medicine and rehabilitation until that preceptorship. And as a cheerleader at heart, I really wanted to be the doctor that motivated my patients to move, kind of progress in their function and move forward mentally and physically. So this graphic is just a simplified explanation for an example of a patient who might present to our outpatient clinic with, for example, low back pain, just to a general physiatry clinic. And some of the aspects of what we as physiatrists do to help treat them. So we would certainly work up their low back pain. We would prescribe physical therapy if it was indicated, if there were medical treatments, such as any medications to help their low back pain, especially if they're having, for example, nerve pain. So there might be like nerve agents that we can try. Other modalities, as you can see here, there's a brace, so lumbar support, constant checkups, follow-ups, monitoring. We've certainly moved a lot of that to telehealth as needed, given these times. And if it's really indicated, we could also refer to surgical treatment. But that being said, as physiatrists, we do have a lot of interventions that we can offer. And that includes things like Botox injections. We can offer steroid injections, whether that's to a specific joint, or epidural steroid injections. We do those. So, it's not as invasive as an orthopedic surgeon, for example, but we work closely with neurologists and orthopods to treat our patients. And so also, actually, one more thing I wanted to mention about physical medicine and rehab that really makes our field different is when I said that we worked closely with specialists, we also work very closely with the physical therapists, the occupational therapists, the speech therapists, and social work, case managers, of course, the patient and the family members too, to understand, the goals of care, how they're progressing in their function, and just make sure that we're prescribing them the correct treatment regimen. And I think that multidisciplinary approach is unique to the physical medicine and rehab specialty. We have team conferences when we are inpatient in the hospital, and then outpatient in clinic, we are often communicating, especially with the therapist, to make sure that our exercise regimen, or if there are any weight-bearing restrictions for these patients, that everything is being followed correctly. So now, why cancer rehabilitation? Often these patients are underserved and undertreated. There is a huge gap in their care from a rehabilitation perspective. They have a new lease on life. When they come to see you, they have such fervor and appreciation for life, and that makes them much more appreciative and receptive to medical recommendations from my own clinical experience. And for me, I get a strong sense of fulfillment with treating this population. And the case that I'm going to be presenting is really was a definitive case in my career that kind of decided what I wanted to do and why I wanted to go into cancer rehabilitation. So you will find out shortly kind of what led me to this path. All right, so here is the case example. There are a few questions. I know that there's a little bit of a delay in the chat, so I will try and wait to see if any questions pop up, or if you guys have answers to any of my questions. So to our cancer rehab clinic, we had an 80-year-old female with cervical cancer, so cancer in the pelvis, who presented with 6 months decline in function from modified independence. So she was using just an assistive device like a cane or a walker to get around. And she had declined in her function to wheelchair level. She had bilateral, so meaning both limbs, right more than left leg weakness. Sometimes you might hear bilateral lower extremity and upper extremity. Upper extremity is arms, lower extremity legs. So she had weakness, numbness, and tingling. The symptoms began about 1 month prior to completion of her cancer treatment. And she previously had underwent chemotherapy with cisplatin and low-dose radiation to her pelvis. One thing that also makes cancer patients unique is this population is really, their treatment can sometimes be worse than the actual diagnosis. And so that is really where the rehabilitation specialists step in to kind of help, especially managing, any complications that can arise. So my question for you is, what questions would you ask this patient? And I can go back to the summary page and I'll wait a little bit. I know it can be a little intimidating. And if there are any terms that you don't understand, please reach out and let me know. I tried to make sure that I explained everything as best I could. Sometimes in medicine, we speak in a different language almost. So, and also with a lot of abbreviations. Where, when does it hurt most? Where does it hurt the most? These are very good questions. Does anything make her weakness, pain, numbness, tingling better or worse? Does it radiate anywhere? How successful was the chemotherapy? I will say the chemotherapy, she had complete remission and success for that. Great questions, family history. I didn't go into too much detail with the family history here, but these are key questions to be asking. Diet changes, is she drinking enough water, getting enough sleep? This is awesome. You guys are doing great. Does the pain change during certain movements? Did the cancer ever metastasize or was it just cervical? These are really great questions. Treatment and lifestyle goals. So one thing that you guys brought up is, or a few things that you brought up is something that kind of goes along with this mnemonic that I was taught in medical school and I still use today. So you think OPQRST when someone comes in with a chief complaint. So O is for onset. I think somebody asked in the beginning, when did this start? Was this acute? Did it start right away, suddenly? Was it subacute? Did it take like a few weeks to months? Or has it been something that's progressively been going on and is chronic now? Has it been years? Palliative versus provocative. I think somebody had asked this as well. What makes it better or worse? Is there a certain movement or activity that makes it better, that makes it worse? Range of motion, any restriction? Quality, can you describe the symptoms? Is it sharp, dull, aching? So you heard me say tingling and numbness. So those are key words there. Radiation, how do your symptoms travel? So oftentimes with numbness and tingling, those are, as I said, keywords, buzzwords that would tip you off to potentially a nerve injury that's going on. And with nerves, they follow a specific pattern. So that's why radiation can be key to figuring out, is it going down the back of your leg, the front of your leg? Does it start in the back? Does it start in the hip? Does it go to your knee? Does it go to your foot, for example? And then severity, on a scale of 1 to 10, 1 being like a hangnail, 10 being the worst pain you can imagine. How would you rate the pain? If you're having pain, how would you rate the tingling sensation? Trying to get an idea for what exactly is happening. And, the other thing to ask here too is, at its best, how would you rate it on a scale of 1 to 10? And at its worst, how would you rate it on a scale of 1 to 10? And then timing, is there a certain time of day or night that this gets better or worse? So what is most likely injured? I kind of broached the subject here a little bit, but for those who have any ideas, please feel free to input it into the chat box. And I'll wait a little bit because I know there is a delay. And I also kind of gave it away a little bit with this picture, but. Nerve damage. Okay. So nerves, great start there. What else could it be? Could it be the nerve roots where the nerves come out? Many are saying nerve. Good. You're paying attention. Could it be the nerve roots? So the other term for that is radicular. So is that, is it coming out of where the nerves come out from the spinal cord and through the neural foramen? Could it be in the spinal cord itself? Could it be in the brain? Now, when you're thinking of nerves, think of these as wires that help your brain communicate with your body via the spinal cord. And now getting back to the case example. So if this were in the spinal cord, or what we like to call the cauda equina area, which is kind of like the tail of the spinal cord, some very concerning things that we might see would be bowel or bladder incontinence. And luckily, she did not have any bowel or bladder issues. She also didn't have any back pain. So, maybe this could be something that's mechanical. Could there be disc herniation that's causing some sort of radicular pain or pattern that is why it's going down her legs? Again, it was the right more than the left, but it was affecting both legs. And while it can happen that you have multiple disc herniations or, both sides of your nerves being affected, usually with a disc herniation, it would be just one side. So when she came to the cancer rehab clinic, there was concern for what is termed chemotherapy-induced peripheral neuropathy. And that is an injury to the nerve secondary to cisplatin. And that was the chemotherapy agent that she was given. I like to think of cisplatin as one of the side effects. It quote unquote splats the DRG, the dorsal root ganglion, which is what controls kind of the sensory findings. So that's kind of where, they heard this numbness and tingling, and they were thinking this could be cisplatin related. That might be getting into a little too much detail there, but in the future, when you guys start studying for your medical exams, hopefully you'll remember that tidbit. So after 6 months of these symptoms, she presented to the Cancer Rehabilitation Clinic. And the presentation of symptoms, it did not correlate with the working diagnosis, especially in the pattern it was presenting, in this kind of radicular pattern following, down her leg, especially on the right more than the left as well. So we did additional studies. Now, this is a tricky question. You would have to know physical medicine and rehabilitation pretty well to answer one of the studies that we did. But can any of you think of what we might have ordered? And I list 2 studies here. I'm just monitoring the chat to see. And if you guys don't have any idea, that's also okay. MRI, very good. So EEG, I think potentially nerve conduction velocity test. I think what you want to say is an EMG. EEG is, yes, EMG, perfect, electromyography. So that is the electrodiagnostic study. EEG is an electroencephalogram. That's what neurologists often will order for patients if they're concerned. They want to see if a patient is having seizures. So there's a little bit of a difference there. And then, of course, there's an EKG, electrocardiogram, or ECG, and that's to look at the heart. But if you think of an EKG and how it's looking at the heart, it's similar to an EMG in how it looks at the muscles. And an EMG, again, electromyography, it's an electrodiagnostic study that physiatrists and sometimes neurologists as well will perform. A study that examines the health of the nerves and muscles through electric stimulation as well as through needles. And it is exactly as whoever had written nerve conduction velocity test, I mean, it is looking at that conduction and how the signal is getting through the nerves. And it, if there's any blockage, if there's any slowing, anything like that. So great answers, you guys. And then MRI, somebody had said MRI. So this is a study that gives more detail of soft tissue organs. And this MRI specifically was done of the pelvic area in a very targeted area. So I will get into that. Obviously, it is not an X-ray, which is what we see here. X-ray photobombing. You can see the bones very well in an X-ray, but you can't really see the soft tissue as well. So EMG and MRI, these were the findings. They revealed injury to a bundle of nerves in a specific pattern. Again, pattern is key, especially with nerves, following a specific path down the leg. That can really be a telltale sign to what's going on. You can think of your body almost as like a map. And in the legs, the nerves come together in what is known as the lumbosacral plexus. And that is what I am showing here in this picture. We have a similar group of nerves for our arms, and that is known as the brachial plexus. And just a little plug here, if you can get started on memorizing the brachial plexus right now, I wish that I had memorized it before I got to medical school, because I remember that was one of the first things we learned. It was very intimidating. And then we had to memorize the lumbosacral plexus as well. And I just remember thinking, what have I been doing with my life? How did I not know the brachial plexus and all its branches? But now it's definitely become very intuitive as a physical medicine and rehabilitation doctor. So this is a T2 weighted MRI. Which means because it is T2, fluid, so think of like H2O, will show up bright or white. And here we see nerve damage to the lumbosacral plexus. I'm not sure if you can see my arrow here, but I'm kind of circling the areas that are white, that's signal enhancement. And that is showing injury to, oh, good. Okay, you can see my arrow. So that is showing injury to the lumbosacral plexus as well as the sciatic nerve too. And the signal enhancement is a little bit brighter on the right side. So the patient, the way that MRIs work, if you think of a patient lying down with their feet coming out toward you, then that's kind of the orientation. So on my left, when I'm looking at this picture, so even on all of you who are looking at this picture, on your left, it's actually the patient's right, and vice versa. So that's really important to, anytime that you're looking at an image, to really orient yourself and understand left versus right, and understanding, the image too. Is it T2 weighted? Is it T1 weighted? So that you know exactly what you're looking at. And you can see here too, here's the vertebrae, and then here's the pelvis, and here's the femur, the femoral head, over here and over here too. And this is what's called a coronal view. So the cut is coming straight down. I think of it as like placing a crown. So it's going to cut down with coronal. So thanks to a multidisciplinary team discussion with specialists, including physiatry, neuroradiology, radiation oncology, and gynecologic oncology, we were able to diagnose this patient with radiation-induced lumbosacral plexopathy. And that really gets into the multidisciplinary approach that I was talking about that is unique certainly to physical medicine and rehabilitation. Thanks to the Cancer Rehabilitation Clinic, She not only received a formal diagnosis, but we were able to address her therapy needs, improving her range of motion, her strength, and gait. 1 year later, she has improved mobility and is now ambulating with a walker. And as I said before, this was a very definitive case that kind of decided my career trajectory in going into cancer rehabilitation. And the key takeaway, it took this patient 6 months to present to our cancer rehab clinic, despite a significant decline in function. 6 months, that's half a year. There is a gap in the care for this population. So you can help us fill it by becoming a cancer rehabilitation doctor. And now moving on to some advice that I would love to impart with all of you future physicians. Remember, it is a marathon, not a sprint. This is what I was told my first day of medical school. And it has stuck with me this entire time because it really is. It's not something you can rush. This is a long process and it's going to take a lot of time. It's going to take commitment, hard work. It's going to be stressful. But you're gonna get through it because if you want it badly enough, you will succeed. That being said, make sure to take care of yourself along the way. Have a really strong support network. There is a lot of talk of medicine being glamorized, whether that's on social media or on TV, and you do have to realize the reality. It doesn't always meet that dream, but in the long run, it will. If you stick with it, you'll feel that sense of fulfillment that I feel with treating the cancer rehabilitation population. The other piece of advice I wanted to impart was on the medical school application timeline, because I understand that many of you are pre-med. So I just want to make sure that you guys, if you haven't already, have at least an idea of what the timeline looks like for preparing your application. So when to take your MCAT, and then, applications accepted, interview season. You want to get your applications in as soon as possible, like right away. You don't want to wait. And not only do you want to get those primary applications in, you want to get those supplemental applications in. As soon as you receive them, you want to submit them. I mean, of course, you want to go through answering them appropriately and getting the essays correct and having them reviewed and edited. But you really, it should be like a quick turnover to get those in. And this concludes my presentation. I have about 10 or 15 minutes to answer any questions, but I do want to let you know, again, this is my contact information. Please feel free to follow me or not follow me if you don't like the content, totally okay, but you can always DM, reach out on Instagram, dr.cole. And then my blog, dailydoseofvita.blogspot.com. This is kind of a blog on lifestyle, my time in residency, my time as a medical student, career, health. And I did just rescue a puppy. So there are some cute puppy pictures up there right now. But I want to let you know, if you can, definitely check it out because I do have some career advice on how to write a personal statement, tips for an interview. I have a blog post on how to know which residency program is right for you, but I think it can apply to which medical school as well. And then the resources that I really enjoyed in medical school. And then if you have any questions, please, again, you can reach out, DM me, or you can email me, dailydoseofvita@gmail.com. I did want to mention I am a medical school admissions consultant. I work for a much larger company. I won't name them here, but I am happy to get this set up, whether it's with me or another medical school admissions consultant. If you are interested, I do mock interviews. I also review essays and applications. I do a lot of kind of editing in that sense and answer any questions that you have. I was part of the admissions team at my medical school and helping kind of orient the incoming prospective medical students. So with that being said, I'm sure you are all tired of listening to my voice. Unfortunately, I can't see any of you or hear any of you, but feel free to type into the chat any questions that you have. And I hope that this was helpful. I hope, even if you don't go into PM&R, that you at least know about the field and can educate others. And when you are a physician, you understand the importance of consulting PM&R or referring to physical medicine and rehabilitation for your patients, because while I do feel laughter is the best medicine, movement is also medicine. Okay, so can you go over how you apply for and get matched for residency? Okay, so the application process for residency, it's very similar to medical school, I would say, in terms of like, you kind of go through the same process, personal statement, gathering the references, and everything. And then it's a whole separate kind of like match program. I know the residency programs have merged, so I'm not as familiar right now with that. I think it was the NRMP was what I had gone through. And I mean, I feel like they could probably just change it to be something as simple as like an app you can just swipe on, but it can be a little bit complicated because you have to come up with like rank lists, and then the residency program ranks you, and then it's like it goes down this kind of algorithm to match following both lists, I guess, for the program itself as well as the candidate. So I'm happy to talk a little bit more. This is probably not the best explanation, and I think it's changed a little with everything merging between the osteopathic and allopathic residency programs, but it's very much kind of like a match process, which I think is happening pretty soon. It's happening, oh gosh, in like 1 or 2 weeks, something like that. So why did you choose DO as opposed to MD school? So I chose the osteopathic school, well, specifically my osteopathic school, because I had shadowed an osteopathic physician who had gone to my medical school. And I remember when I was working with him, I thought he was incredible. I loved his approach to patient care. He would sit down at eye level to talk with the patients, and you could tell that he just had this great rapport and relationship with them. And I got to see him do osteopathic manipulative medicine, and I also got to see kind of how much relief these patients had from it. So it was really him who convinced me to go specifically to the medical school I went to, but also to follow an osteopathic medical career path. Like I said before, I really liked the foundation of osteopathic manipulative medicine. I feel like it gave me a really strong background in anatomy, as well as the musculoskeletal system and neurology. And I liked the holistic approach, the idea that everything is connected, this concept of treating the person as a whole and not just their disease. Did you take both the COMLEX and USMLE for residency? If so, what was that like? Great question. So I did take COMLEX level 1 and USMLE step 1 for the beginning boards. And then afterward, I realized especially going into physical medicine and rehabilitation, it's a very DO friendly field. And it wasn't required for any of the residency programs I applied for. And again, I applied for MD or otherwise known as allopathic as opposed to osteopathic residency programs. And they didn't require me to have USMLE step 1 or step 2. So I never took step 2. I never did the USMLE physical exam, like clinical skills portion either. And I also realized, I mean, even looking back, now what I tell osteopathic medical students who are debating, do I take COMLEX or USMLE, I tell them, if they are not going to accept your COMLEX score, do you really want to be in a residency program that's not going to recognize your osteopathic board certification? Because I really felt strongly that, I wouldn't want to be in a residency program that wouldn't do that. And the requirement might even have changed now that everything's merged. And then Two is you need to pass your COMLEX to graduate. You need to pass those board exams in order to graduate from osteopathic medical school. So I think that, well, to graduate and then become board certified, of course. So I think, figure out your priorities. And then you asked what it was like to study for both. I think, it was great. The more you study, the more you learn, the more you know. I probably was the smartest I've ever been right before I took step one. And I will say it was very helpful to have a study buddy. Definitely like study in groups if you can, not too big so that it's like distracting or anything. But I had an amazing study partner throughout medical school. And I'm really grateful for that. It definitely helped kind of like understand different perspectives and approach to the material. Okay. How has the pandemic changed your work? So we have definitely moved to a lot more telemedicine. And then for the fellowship I'm in right now, so this is the very first fellowship program in cancer rehabilitation here in the city of Philadelphia. And I would say that has changed the, I guess, structure of the program initially because I was hoping to get time with the specialists, like the oncologists in the beginning, but because of the pandemic, we weren't able to have additional learners in clinics. So a lot of telehealth was taking place. And then I was doing a lot of consults inpatient in the hospital and then also seeing patients at our acute rehab facility. And now I'm luckily fully vaccinated and a lot has changed and improved. So I am able to spend a lot more time with the specialists shadowing and getting a really good grasp on cancer treatments, different regimens, complications that I might see, and how I can help the oncologist specialists. And then let me see, the next question, would you say that it is more difficult to match into a specialty with a DO versus an MD, or is this going away with the merging? That's a great question. I'm not entirely sure how to answer that, only because I don't know with this merging process what it looks like for the match process. I think we'll have a lot of answers once we see the match take place in just a few short weeks. But I think that at this point, I mean, like I said, I work side by side with MDs, and I know several DOs who have gotten into competitive specialties from neurosurgery to dermatology. So I think, if you want it badly enough, and whether you're a DO or an MD, you will succeed. So, you just have to make sure that you have the commitment, the passion, the drive to achieve that goal. Let's see. What was your most successful approach in preparing for the MCAT? Oh, so for the MCAT, I did Kaplan. That was what I did. For the MCAT, I did Kaplan, but for COMLEX, I did what was called Doctors in Training, and I loved the Doctors in Training course. But yes, for the MCAT, I did it was an online, like virtual MCAT prep course. And I found that to be the most helpful. That like raised my score up significantly. If you ask me what my score is, I'm so sorry, I don't remember. And I also don't think it would help because the scores changed. Like I think what was considered a competitive score for the MCATs was like in the 30s. And now it's in the 500s. So I think there's probably some conversion that takes place. Okay, so does PM&R tend to be more academic or private practice? It's a mix of both. You can do either. There's always going to be a PM&R department in an academic setting, but I know plenty of people who go into private practice as well. It just depends what your interests are. I'm planning on going into academics, but I have friends who have gone into private practice. And that could include, doing sports medicine private practice, doing pain medicine, interventional spine medicine private practice. But yeah, that's a great question. I'm just seeing if the chat has any other questions. This is really great to get a chance to talk with all of you. Again, I'm sad that I don't get to actually see you. and speak with you, but I'm more than happy to talk more via email. There's one more question. What helped you prepare for your interviews in medical school? Practice, 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 practice. So I would say that if you have a list of questions, for like a list of interview questions that you can then go through and kind of answer and have, you know, it doesn't have to be memorized, or you don't want it to sound rehearsed, but you have some guidelines for how you'd like to answer some difficult questions. For example, of course, there's going to be the bullet statement for tell me about yourself. Or my question that I had during my first medical school interview, which was also the medical school that I ended up going to, they asked me, tell me about from the time that you were born to how you ended up in that chair. And that was a very difficult question, but I had prepared for it because I had practiced. I had plenty of time working with family, with friends, as well as doing mock interviews with my pre-health advising center over in college. So, I would say definitely take advantage of those resources if you can. You can also record yourself speaking so that you notice if you have any repetitive sayings that you say. You can hear me now. I'm saying or and stuff is something that I often say, or like. So you definitely want to try and avoid saying that. So recording yourself can help. And then seeing, what you're doing with your hands, if you're making strange gesticulations, that can help to record yourself, and timing yourself too. You really want to answer the question. The other advice I would give for preparing for your interviews is to research who is going to be interviewing you if you can. I think that really helps as a physician or any professor. Often they like to talk about themselves. So, it definitely helps to know a little bit about their background, their research. It could also be a great networking opportunity or connection. I definitely have a lot more tips too. Again, you can find them on my blog, or if you want, I am, as I said, a medical school admissions consultant, so I'm happy to chat with you more about that. Okay. What's some advice that you would like to give for I think that is high school students majoring in medical science. Let me see. Let me just make sure. Okay. High school students majoring in medical science. I'm going to kill two birds with one stone because somebody asked what's the difference between allopathic versus osteopathic. So what I'm going to do is go backtrack on my slides. You can also find it again on my Instagram at dr.cole, or you can find it on my blog. But here is the slide for DO versus MD to hopefully answer that question while I answer this question. Advice for, I think it's high school students majoring in medical science. So I would say take advantage of any shadowing opportunities you can. Obviously, right now it's a little bit restricted with COVID, but I think networking, getting to know physicians in your area, even talking with your own doctors to have that experience. So as you get into the next stage in your career, you kind of have a little bit of foundation in the building steps that go into it. And also think about, you're interested in medicine. Are you interested in becoming a physician? Are you interested in becoming a nurse practitioner, a nurse, a physician assistant? Recognize the differences in each of these fields so that you know where you want to go and what your goals are with your career. Okay. Academic medicine versus private practice. So academic medicine, it's of course, you're hired as essentially an assistant or associate professor. There's definitely going to be research opportunities, teaching, and you'll have residents, medical students that you'll get to work with. Oftentimes, it is a healthcare system that can kind of make the rules a lot of the time. So there can be a lot of politics involved and administration, some hurdles people might see to academic medicine, whereas private practice, especially if you open up your own practice, then it's kind of like, well, you're in control and you do your own billing, or whatever kind of private practice hires you might do some aspect of the billing. But it's definitely very different. I hope that helped to answer that question. Okay, so do you tend to perform more interventional procedures, or do you take a more medication-based approach? And I have to leave in just a couple minutes, so I'm going to try and get a couple more of these questions. Okay, so interventional procedures. I have done a few during my residency, especially like epidural steroid injections. But as a cancer rehabilitation physician, I do more, I would say, I do steroid injections, trigger point injections, Botox injections for like spasticity or any sort of radiation fibrosis. So there's like a restriction in the range of motion for patients who have, for example, head and neck cancer. So I might administer Botox to their neck muscle, their cervical muscles. And then certainly, medications are a great adjunct therapy. But as I had mentioned, again, we work very closely with the physical therapist, occupational therapist, speech therapist, and we really try to emphasize movement as much as we can. And then in addition, I also can offer osteopathic manipulative medicine to my patients. Okay, hopefully that helped to answer that question. Any advice for reapplicants? So what the main question that they're going to want to know if you're a reapplicant is, what have you been doing between the time that you applied initially and now? And the fact that you're here at this shadowing session speaks volumes about what you've been doing. You're taking advantage of any opportunity to learn more about different specialties, including cancer rehabilitation. So I think that's something to emphasize. And any publications, research that have come out, or presentations that you've done, make sure to include those on your resume. Do you think med schools are going to have to take into account virtual medical experience during these times? So let's see. During these times, I think they will. I think they should. This is how you are innovating and adapting to these times. We've had to go virtual, so I can't imagine that they wouldn't. And I think this is certainly a new baseline for all of us. So I think I would emphasize any shadowing experience that you had, whether it was virtual or in person. And with that, thank you for joining this virtual session. Hopefully I'll get to meet some of you in person at some point. But again, you can connect with me on social media or just take a look at my blog. I'll leave my contact information here. And I actually have to go because I have a virtual interview coming up. So I would say wish me luck, but really I hope that I wish you all more luck because you guys are in a really exciting time. And I hope that this helped. Best of luck. Please let me know if you have any other questions. Here's my contact information. And I'm really excited to hopefully get to work with some of you in the future.
Thank you so much, Dr. Cole, for presenting for our web shadowers. We loved your presentation and how informative it was. And thank you so much for answering all of our questions.
Of course, absolutely. All right, well, take care, everyone. Stay safe, and hopefully I'll hear from you soon. If you want me back, let me know. I'm happy to present on something else, okay?
We'd love to have you back. Thank you. Everyone, make sure you check out her socials. Her Instagram is dr.cole.
Additionally, thank you all for attending. The February roundup will start tonight at 11:59 p.m. EST, and the forums will close on February 28th, this Sunday, at 11:59 p.m. EST. For more information, please head over to our Instagram at WebShadowers, and that's where we will be having our news and our updates regarding it.
The link to today's Google form has now been posted in the chat. And it'll be in the description of this video shortly. Please fill it out within the next 30 minutes for us to receive verification of your attendance.
Again, thank you all so much for attending, and we look forward to seeing you.